Menstrual disorders. Many women sail through their monthly cycles with little or no concern. With few symptoms to worry about, their menses are like clockwork, starting and stopping at nearly the same time every month. For others, the menstrual cycle causes physical and emotional symptoms that initiate visits to their healthcare providers for consultation. The following menstrual-related conditions will be discussed in this video: amenorrhea, dysmenorrhea, dysfunctional uterine bleeding or DUB, premenstrual syndrome or PMS, premenstrual dysmorphic disorder or PMDD, and endometriosis. Amenorrhea is the absence of menses during the reproductive years. Amenorrhea is normal in prepubertal, pregnant, postpartum, and postmenopausal females. The uterus, the endometrial lining, the ovaries, the pituitary, and the hypothalamus must all function properly and in harmony with one another for a menstrual cycle to occur. The two categories of amenorrhea are primary amenorrhea and secondary amenorrhea. Primary amenorrhea is defined as one of the following: either the absence of menses by age 14 with the absence of growth and development of secondary sexual characteristics, or the absence of menses by the age of 16 with the normal development of secondary sexual characteristics. 98% of American girls begin menstruation by the age of 16. Secondary amenorrhea is the absence of menses for 3 cycles or 6 months in women who have previously menstruated regularly. Primary amenorrhea has multiple causes, including extreme weight loss or weight gain, congenital abnormalities of the reproductive system, stress from major life events, excessive exercise, eating disorders such as anorexia nervosa or bulimia, Cushing's disease, polycystic ovary syndrome, hypothyroidism, Turner syndrome, imporphyrate hymen, chronic illnesses including diabetes, thyroid disease or depression, pregnancy, cystic fibrosis, congenital heart disease, or tumors of the ovaries or adrenal glands. Causes of secondary amenorrhea include pregnancy, breastfeeding, emotional stress, pituitary, ovarian, or adrenal tumors, depression, hyperthyroidism or hypothyroidism, malnutrition, hyperprolactinemia, rapid weight loss or weight gain, chemotherapy or radiation therapy to the pelvic area, vigorous exercise such as long-distance running, colitis, kidney failure, use of certain tranquilizers or antidepressants, postpartum pituitary necrosis, or early menopause. Therapeutic intervention depends on the cause of the amenorrhea. The treatment of primary amenorrhea involves the correction of the underlying disorder and estrogen replacement therapy to stimulate the development of secondary sexual characteristics. If a pituitary tumor is the cause, it may be treated with drug therapy, surgical resection, or radiation therapy. Surgery may also be needed to correct any structural abnormalities of the genital tract. Dopamine agonists are effective in treating hyperprolactinemia. In most cases, the treatment restores normal ovarian endocrine function and ovulation. Therapeutic interventions for secondary amenorrhea include cyclic progesterone when the cause is anovulation or oral contraceptives, bromocriptine to treat hyperprolactinemia, nutritional counseling to address anorexia, bulimia, or obesity, gonadotropin-releasing hormone or GnRH when the cause is a hypothalamic failure, or thyroid hormone replacement therapy when the cause is hypothyroidism. Some tips for maintaining a healthy lifestyle for women wanting to stay reproductively healthy or women experiencing reproductive issues are the following: balance energy expenditure with energy intake, modify the diet to maintain an ideal weight, avoid excessive use of alcohol or mood-altering or sedative drugs, avoid cigarette smoke, identify areas of emotional stress and seek assistance to resolve them. Balance work, recreation, and rest. Maintain a positive outlook regarding the diagnosis and prognosis. Participate in ongoing care to monitor any medical conditions. And maintaining bone density. Maintaining bone density can involve one or more of the following: a calcium intake of between 1,200 to 1,500 milligrams daily, vitamin D intake of 1,000 IUs daily, weight-bearing exercise for 30 minutes or more daily, and hormone therapy. Dysmenorrhea refers to painful menstruation. This condition has also been termed cyclic perimenstrual pain. The term dysmenorrheal is derived from the Greek word dys, meaning difficult, painful, or abnormal, and rhea, meaning flow. Dysmenorrhea may affect more than half of menstruating women. Uterine contractions occur during all periods, but in some women, these cramps can be frequent and very intense. Dysmenorrhea is classified as primary when they are spasmodic, or secondary when it is more congestive. Primary dysmenorrhea is caused by an increase in prostaglandin production by the endometrium during the ovulatory cycle. This hormone causes the contraction of the uterus, and levels tend to be higher in women with severe menstrual pain than in women who experience mild or no menstrual pain. Prostaglandin levels are the highest during the first 2 days of menses when symptoms usually peak. This results in an increase in rhythmic uterine contractions caused by vasoconstriction of the small blood vessels of the uterine wall. This condition usually begins within a few years of the onset of the ovulation cycles at menarche. Secondary dysmenorrhea is painful menstruation due to pelvic or uterine pathology. It may be caused by endometriosis, adenomyosis, pelvic inflammation, fibroids, an intrauterine device, cervical stenosis, or congenital uterine or vaginal abnormalities. Adenomyosis involves the ingrowth of the endometrium into the uterine musculature. Endometriosis involves the ectopic implantation of endometrial tissue in other parts of the pelvis. This condition occurs most commonly in the third or fourth decades of life and affects 10% of women of reproductive age. Endometriosis is the most common cause of secondary dysmenorrhea and is associated with pain beyond menstruation, dyspareunia, low back pain, and infertility. Treatment is directed toward removing the underlying pathology. Severe dysmenorrhea can be distressing, adversely affecting social and occupational activities. Treatments vary from over-the-counter remedies to hormonal controls. However, for some women, satisfactory pain relief is difficult to achieve, and alternative options are increasingly being sought. Complementary therapies such as acupuncture are gaining popularity, and the evidence base for their use is growing. Therapeutic intervention is directed toward pain relief and building coping strategies that will promote a productive lifestyle. Treatment measures usually include treating infections if present, suppressing the endometrium if endometriosis is suspected by administering low-dose oral contraceptives, administering prostaglandin inhibitors to reduce pain, administering Depo-Provera to suppress ovulation, which thins the endometrial lining of the uterus with subsequent reduction of fluid contents of the uterus during menses, and initiating lifestyle changes. Dysfunctional uterine bleeding. Disturbances of menstrual bleeding manifest in a wide range of presentations. Abnormal uterine bleeding is the umbrella term that is used to describe any deviation from normal menstruation or from a normal menstrual cycle pattern. The key characteristics are regularity, frequency, heaviness of flow, and duration of flow. However, each of these may exhibit considerable variability. More descriptive terminology is currently being deliberated internationally. Dysfunctional uterine bleeding, otherwise known as DUB, is a disorder that occurs most frequently in women at the beginning and end of their reproductive years. Defined as irregular abnormal bleeding that occurs with no identifiable anatomic pathology, it affects up to 50% of women. It is frequently associated with anovulatory cycles, which are common during the first year after menarche and later in life as women approach menopause. The pathophysiology of DUB is related to a hormonal disturbance. With anovulation, estrogen levels rise as usual in the early phase of the menstrual cycle. In the absence of the ovulation, however, a corpus luteum never forms and progesterone is not produced. The endometrium then moves into a hyperproliferative state, ultimately outgrowing its estrogen supply. This leads to irregular sloughing off of the endometrium and excessive bleeding. If the bleeding is heavy enough and frequent enough, anemia can actually result. DUB is similar to several other types of uterine bleeding disorders and sometimes overlaps with these conditions. These may include menorrhagia, which is abnormally long or heavy periods, oligomenorrhea, which is bleeding that occurs at intervals of more than 35 days, metrorrhagia, which is bleeding between periods, endometriosis, which is bleeding that occurs at irregular intervals with heavy flow lasting more than 7 days, or polymenorrhea, which is periods that occur much more frequently than is usual. Some of the possible causes of DUB may include adenomyosis, pregnancy, hormonal imbalances, fibroid tumors, endometrial polyps or cancer, endometriosis, intrauterine systems, polycystic ovary syndrome, morbid obesity, steroid therapy, hypothyroidism, and blood clotting disorders. The treatment of DUB depends on the cause of bleeding as well as the age of the client. When known, the underlying cause of the disorder is treated. Otherwise, the goal of the treatment is to normalize the bleeding, correct the anemia, prevent or diagnose early cancer, and restore quality of life. Management of DUB might include medical care with pharmacotherapy or insertion of a hormone-secreting intrauterine system. Oral contraceptives are used for cycle regulation as well as contraception. They help to prevent the risks associated with prolonged, unopposed estrogen stimulation of the endometrium. NSAIDs, pain relievers, and progestin therapy decrease menstrual blood loss significantly. The drug categories used in the treatment of DUB include estrogens, progestins, oral contraceptives, NSAIDs, progesterone-releasing intrauterine systems, androgens, and iron salts. Estrogens work by causing vasospasms of the uterine arteries to decrease bleeding. Progestins are used to stabilize an estrogen-primed endometrium. Oral contraceptives are used to regulate the menstrual cycle and suppress the endometrium. NSAID pain relievers inhibit the prostaglandins that are secreted in the ovulatory menstrual cycle. Progesterone-releasing intrauterine systems suppress endometrial growth. Androgens create a high androgen, low estrogen environment that inhibits the endometrial growth, and iron salts act to replenish iron stores that may be lost during heavy bleeding. When the client does not respond to medical therapy, surgical intervention might include dilation and curettage, endometrial ablation, or hysterectomy. Endometrial ablation is an alternative to hysterectomy. Techniques used for ablation include laser, electrosurgery excision procedures, freezing, heated fluid infusion, or thermal balloon ablation. Most women will still have regular menstrual flow following endometrial ablation, and up to half will stop having periods. Younger women are less likely than older women to respond to endometrial ablation. Recent scientific evidence supports that up to 1/4 of clients treated with endometrial ablation require repeated ablation procedures or subsequent hysterectomy to stop DUB. Hysterectomy should be considered as a last resort for the treatment of DUB when blood loss impedes health. Premenstrual syndrome. Premenstrual syndrome, or PMS, describes a constellation of recurrent symptoms that occur during the luteal phase or last half of the menstrual cycle and usually resolve with the onset of menstruation. The American College of Obstetrics and Gynecologists defines premenstrual syndrome as the cyclic occurrence of symptoms that are sufficiently severe enough to interfere with some aspect of life and that appear with a consistent and predictable relationship to menses. A woman experiencing PMS may have a wide variety of seemingly unrelated symptoms. For that reason, it is difficult to define and more challenging to diagnose PMS. PMS affects millions of women during their reproductive years. Up to 75% of menstruating women report on having one or more premenstrual symptoms, and up to 10% report disabling, incapacitating symptoms. The exact cause of PMS is not known. It is thought to be related to the interaction between hormonal events and neurotransmitter function, specifically serotonin. Not all women respond to serotonin reuptake inhibitors, or SSRIs, which implies that there may be other mechanisms involved as well. According to the American Psychiatric Association, premenstrual dysmorphic disorder, or PMDD, is a more severe variant of PMS, affecting between 3 and 6% of premenopausal women. Experts compare the difference between PMS and PMDD to the difference between a mild tension headache and a migraine. PMDD markedly interferes with work, school, social activities, and relationships with others. Treatment of PMS is often frustrating for both clients and healthcare providers. Clinical outcomes can be expected to improve as a result of recent consensus on the diagnostic criteria for PMS and PMDD. The management of PMS or PMDD requires a multidimensional approach because these conditions are not likely to have a single cause, and they appear to affect multiple systems within a woman's body. Therefore, they are not likely to be amenable to treatment with a single therapy. To reduce the negative impact of premenstrual disorders on a woman's life, education, along with reassurance and anticipatory guidance, is needed for women to feel that they have some control over this condition. Therapeutic interventions for both PMS and PMDD address the symptoms because the exact cause of the condition is still unknown. Treatments may include vitamin supplements, dietary changes, exercise, lifestyle changes, and medications. The medications used in treating PMDD include antidepressants and anti-anxiety drugs, along with diuretics, anti-inflammatory medications, pain relievers or analgesics, synthetic androgen agents, oral contraceptives, or gonadotropin-releasing hormone agonists. Here are some treatment options for PMS and PMDD. The first category are lifestyle changes. Reduce stress. Exercise 3 to 5 times each week. Eat a balanced diet and increase water intake. Decrease caffeine intake. Stop smoking if you do, and limit the intake of alcohol. And attend PMS or women's support groups. There are also vitamin and mineral supplements which may help, including a daily multivitamin, vitamin E at 400 units daily, calcium at 1200 milligrams daily, and magnesium at a dose of between 200 and 400 milligrams daily. Medications that can be used include NSAIDs or pain relievers that are taken a week prior to menses, a low-dose oral contraceptives, or antidepressants, also known as SSRIs. Anxiolytics, which are taken during the luteal phase of the menstrual cycle, diuretics to remove excess fluid, progestins, gonadotropin-releasing hormone agonists, and danazol, which is an androgen hormone which inhibits estrogen production. No single treatment is universally recognized as effective, and many clients often turn to therapeutic approaches outside of conventional medicine. Many women use dietary supplements or herbal remedies for their menstrual health and treating their bleeding disorders, although there has been little research to demonstrate their efficacy. Alternative therapies include the use of calcium carbonate, magnesium, vitamin B6, evening primrose oil, Vitex agnus castus, ginkgo biloba, viburnum, dandelion, stinging nettle, chaste tree berry, burdock, raspberry leaf, skullcap, and St. John's wort. Although research has not validated the efficacy of these alternative therapies, it is important for the nurse to be aware of the alternative products that women may choose to use. In PMDD, the main symptoms are mood disorders such as depression, anxiety, tension, and persistent anger or irritability. Physical symptoms such as headache, joint and muscle pain, lack of energy, bloating, and breast tenderness are also present. It is estimated that up to 75% of reproductive age women experience premenstrual symptoms that meet the criteria for PMS, and up to 10% meet the diagnostic criteria for PMDD. According to the American Psychiatric Association, a woman must have at least 5 of the typical symptoms to be diagnosed with PMDD. These must occur during the week before and a few days after the onset of menstruation, and must include 1 or more of the first 4 symptoms, as follows. Affective liability, including sadness, tearfulness, or irritability, anxiety and tension, persistent or marked anger or irritability, depressed mood or feelings of hopelessness, difficulty concentrating, sleep difficulties, an increase or decreased appetite, an increase or decrease in sexual desire, chronic fatigue, headache, constipation or diarrhea, or breast swelling and tenderness. Endometriosis. Endometriosis is one of the most common gynecological diseases, affecting more than 6 million women in the United States. This is equal to about 10% of the adult women population. In this condition, portions of functioning endometrial tissue become located outside of their normal sites, which is the uterine cavity. This endometrial tissue is commonly found attached to the ovaries, fallopian tubes, the outer surface of the uterus, the bowels, the area between the vagina and the rectum, called the rectovaginal septum, and the pelvic side wall. The places where the tissue attaches are called implants or lesions. Endometrial tissue found outside the uterus responds to hormones released during the menstrual cycle in the same way that the endometrial lining does within the uterus. At the beginning of the menstrual cycle, when the lining of the uterus is shed and menstrual bleeding occurs, these abnormally located implants also swell and also bleed. In short, the woman with endometriosis experiences several mini periods throughout her abdomen wherever this endometrial tissue exists. It is not currently known why endometrial tissue becomes transplanted and grows in other parts of the body. Several theories exist, but to date none have been scientifically proven. However, several factors are known to increase a woman's risk of developing endometriosis. This includes increasing age, a familial history of endometriosis in a first-degree relative, short menstrual cycles less than 28 days long, a long menstrual flow of more than 1 week, a high dietary fat consumption, a young age of menarche, younger than 12 years of age, and few, 1 or 2 or no pregnancies. Therapeutic management of the client with endometriosis needs to take into consideration the following factors: the severity of the symptoms, the desire for fertility, the degree of the disease, and the client's therapy goals. The aim of therapy is to suppress levels of estrogen and progesterone, which cause the endometrium to grow. Treatment can include surgery or medications such as oral contraceptives, Depo-Provera, synthetic testosterone, and GnRH agonists. The 2 most common symptoms for women with endometriosis is infertility and pelvic pain. Endometriosis occurs in about 38% of infertile women and 71 to 87% of women with chronic pelvic pain. About 30 to 40% of women with this condition are infertile, making it one of the top 3 causes of female infertility. The pelvic examination typically correlates with the extent of the endometriosis. The usual finding is nonspecific pelvic tenderness. The hallmark finding is the presence of tender nodular masses on the uterosacral ligaments, the posterior uterus, or the posterior cul-de-sac. The only definitive diagnosis is one that's made during surgery. After a thorough history and pelvic examination, the healthcare practitioner may suspect endometriosis, but the only certain method of diagnosis is by seeing it. Pelvic or transvaginal ultrasound is used to assess pelvic organ structures. However, a laparoscopy is needed to truly diagnose endometriosis. Laparoscopy is the direct visualization of the internal organs with a lighted instrument that is inserted through an abdominal incision. A tissue biopsy of the suspected implant is then taken at the same time and examined microscopically to confirm the diagnosis. Thank you for watching.